Welcome to our first video on spinal cord diseases. Let's begin. In this lecture, we're going to discuss anterior cord syndrome, central cord syndrome, and Brown-Sequard syndrome. We'll discuss definition, etiology, clinical features, diagnosis, and management of anterior cord syndrome. Anterior cord syndrome is defined as damage of the tracts in the two anterior thirds of the spinal cord. These include corticospinal tracts, spinothalamic tracts, and descending autonomic tracts. Here is a cross-section of the spinal cord. In the anterior cord syndrome, this region is affected. This leads to damage of spinothalamic tracts, corticospinal tracts, and descending autonomic tracts. There are several causes of anterior cord syndrome. The most important of these is anterior spinal artery injury, which can occur due to infarction, intervertebral disc herniation, or vertebral burst fracture. Also, radiation myelopathy can result in anterior cord syndrome. Here we can see an illustration showing the anterior spinal artery. An injury to this artery will result in damage of this region, which leads to anterior cord syndrome. Let's move on to the clinical features. They actually reflect what is damaged among the spinal tracts. So first of all, the damage of lateral corticospinal tracts manifests with bilateral hemiparesis at and below the lesion level. For example, a lesion involving the corticospinal tracts at T10 level will lead to spastic paralysis in lower extremities. Damage of lateral spinothalamic tracts results in bilateral loss of pain and temperature sensation below the lesion level. Lastly, damage of autonomic tracts that are descending to the sacral cord results in urinary incontinence. Remember that the dorsal tracts are intact in anterior cord syndrome, so the proprioception and vibratory sensation are normal. For the diagnosis of our syndrome, clinical examination is essential. However, MRI is usually used to help identify the cause. Regarding the management, we should treat the underlying cause if applicable. Also, surgical decompression can be performed. A 48-year-old man comes to the physician for a follow-up visit. He was involved in a motor vehicle accident 3 months ago. Since then, he has been using a wheelchair due to paraparesis. The physical exam reveals spasticity and 4+ deep tendon reflexes in the lower extremities. The pain and temperature sensation are also lost in the legs. However, proprioception and vibration sensation are intact. The physical exam of upper extremities is unremarkable. What is the most likely diagnosis? This patient has been using a wheelchair due to paraparesis after he was involved in a motor vehicle accident. The physical exam reveals spasticity and 4+ deep tendon reflexes in the lower extremities. These findings indicate a UMN lesion and damage to the lateral corticospinal tract. The pain and temperature sensation are also lost in the legs, suggesting damage to the lateral spinothalamic tracts. The proprioception and vibration sensation are intact, which means the dorsal column's intact as well. Damage to all the major tracts except for the dorsal column suggests the diagnosis of anterior cord syndrome. Let's recall that anterior cord syndrome is most commonly caused by the injury of anterior spinal artery. Let's move to our next topic, central cord syndrome. We'll discuss causes, clinical features, diagnosis, and management of central cord syndrome. First of all, it is worthy to note that central cord syndrome is the most common among incomplete cord syndromes. It's usually caused by a lesion in the center of the spinal cord that disrupts the nearby tracts. For example, syringomyelia and intramedullary tumors. It can be caused by hyperextension injury in patients with cervical spondylosis. Here's a cross-section of spinal cord. In central cord syndrome, this region is involved. This results in damage of spinothalamic fibers in the anterior white commissure and the anterior horn cells. The clinical features of central cord syndrome reflect what is damaged among the structures of spinal cord. So, damage of spinothalamic fibers in the anterior white commissure results in bilateral loss of pain and temperature sensation at the lesion level. These sensations are normal below and above the lesion level, which creates a suspended sensory level detected on physical exam. When the lesion extends to compress the anterior horn neurons, manifestations of lower motor neuron lesion can be seen. These include flaccid weakness and diminished deep tendon reflexes at lesion level. For the diagnosis of central cord syndrome, clinical examination is essential. However, MRI is the imaging test of choice to identify the cause. It can detect syringomyelia, tumors, and other masses. Regarding the management, we should treat the underlying cause if that is applicable. Physical and occupational therapy can be provided. Also, surgical intervention may be considered. A 37-year-old woman comes to the physician after accidentally burning her hands on the grill. She did not feel the heat or pain from the burn. The physical exam reveals loss of pain and temperature sensation, along with flaccid weakness and 1+ deep tendon reflexes in both upper extremities. The neurologic exam of the lower extremities is unremarkable. What is the most likely diagnosis? This woman burned her hands on the grill, but she did not feel the heat or pain from the burn. The physical exam reveals loss of pain and temperature sensation only in the upper extremities, suggesting injury to the spinothalamic fibers in the anterior white commissure. Additionally, there is flaccid weakness and hypoactive deep tendon reflexes in the upper extremities, indicating injury to the ventral or anterior horns at the cervical cord level. These findings point to the diagnosis of central cord syndrome. Let's recall that the central cord syndrome damages anterior white commissure and later the anterior horns. Let's move to our next topic, Brown-Sequard syndrome. We'll discuss definition, etiology, clinical features, diagnosis, and management of Brown-Sequard syndrome. Brown-Sequard syndrome is hemisection of the spinal cord. This can be caused by trauma, most commonly a penetrating trauma. Mass lesions such as tumors and hematoma may also be implicated. Here's a cross-section of the spinal cord. In Brown-Sequard syndrome, this side or the other side is affected. This results in damage of spinothalamic tracts, corticospinal tracts, dorsal column, and anterior horn cell. Let's pay special attention to the clinical features of Brown-Sequard syndrome, as they are frequently tested on the Step 2 CK exam. Damage of the lateral corticospinal tracts results in ipsilateral hemiparesis at and below the lesion level. Also, damage of the dorsal columns results in ipsilateral loss of proprioception and vibration sensation at and below the lesion level. Why are the manifestations here ipsilateral? Recall from our lecture on localizing neurologic lesions that symptoms and signs are ipsilateral when the lesion is below the decussation site of the tract. Corticospinal tracts and dorsal column pathway decussate in the brainstem. Let's continue. When the lateral spinothalamic tracts are damaged, there is contralateral loss of pain and temperature sensation starting 1 to 2 levels below the lesion. Again, recall from our lecture on localizing neurologic lesions that symptoms and signs are contralateral when the lesion is at or above the decussation site of tract. Spinothalamic fibers decussate at the spinal cord. Lastly, if the lesion affects the cervical cord, sympathetic pathways can be damaged. This results in ipsilateral Horner syndrome. On neurologic exam, sensory level can be detected. But what is the sensory level? Recall that sensory level is the lowest level detected on physical exam with normal pinprick and light touch sensation. The sensation is absent or diminished below the sensory level. Let's take a look at this cross-section of spinal cord. If this side is the left one, and a lesion damages this side leading to Brown-Sequard syndrome, then the corticospinal tract will be affected, causing ipsilateral hemiparesis below the lesion level. The dorsal tracts will be involved too, leading to ipsilateral loss of proprioception and vibratory sensation below lesion level. When the spinothalamic is damaged, a contralateral loss of pain and temperature sensation will be detected starting 1 or 2 levels below the lesion. For the diagnosis of Brown-Sequard syndrome, clinical examination is essential. MRI is the imaging test of choice as it is useful to identify the cause. Regarding the management, early administration of steroids should be done. We should treat the underlying cause if this is applicable. Also, physical therapy and occupational therapy are usually considered. A 52-year-old man is evaluated in the hospital 2 days after being involved in a motorcycle accident. The neurologic exam reveals spastic paresis of the right lower extremity with 4+ deep tendon reflexes. There is loss of vibration sensation and proprioception in the right leg. The pain and temperature sensation are lost on the left lower extremity below the level of inguinal ligament. What is the most likely diagnosis in this patient? This man presents with neurologic deficits shortly after being involved in a motorcycle accident. The neurologic exam reveals spastic paresis of the right lower extremity with 4+ deep tendon reflexes. These findings indicate an upper motor neuron lesion and damage of the corticospinal tract. There is loss of vibration sensation and proprioception on the right leg, suggesting damage to the dorsal columns. Finally, the pain and temperature sensation are lost on the left lower extremity below the level of inguinal ligament. This clue points to damage to the spinothalamic tract. All these neurologic deficits within the context of trauma suggest the diagnosis of Brown-Sequard syndrome. In Brown-Sequard syndrome, the pain and temperature sensation are lost 1 to 2 levels below the lesion. Inguinal ligament coincides with the L1 dermatome. The spinal cord segments 1 to 2 levels above L1 will be T11 or T12. Therefore, the patient has Brown-Sequard syndrome with right T11 T12 segment transection. Let's end our lecture with a board-style question. A 67-year-old female presents to the emergency department due to spastic paralysis of both lower extremities. The patient also admits to recently experiencing incontinence more frequently. On further examination, it is found that she has loss of pain and temperature sensation in both lower extremities. However, her vibration sense and proprioception are intact bilaterally. The patient is sent for an MRI which reveals a herniated vertebral disc compressing a nearby artery. Based on this patient's presentation, which of the following spinal tracts are most likely damaged? A. Dorsal columns and lateral spinothalamic tract. B. Lateral spinothalamic and corticospinal tracts. C. Anterior horn neurons and spinothalamic tract. D. Lateral spinothalamic tract and cervical sympathetics. This 67-year-old female presents with spastic paralysis of both lower extremities, incontinence, and loss of pain and temperature sensation in both lower extremities. She also has her vibration sense and proprioception intact bilaterally. Based on the patient's symptoms, she is experiencing anterior cord syndrome. This is confirmed by MRI, showing a herniated lumbar disc, which is most likely compressing the anterior spinal artery causing the syndrome. Anterior spinal injury damages the lateral corticospinal tracts, causing bilateral spastic paralysis at and below the lesion level. It also damages the lateral spinothalamic tracts, causing bilateral loss of pain and temperature sensation. It damages the autonomic tracts descending to the sacral cord, causing incontinence. It spares the dorsal column, which is why there is intact vibration sense and proprioception. Since this patient has anterior cord syndrome, she has damage to the lateral spinothalamic and corticospinal tracts, making answer choice B correct. Here's a slide reminding us of clinical features of anterior cord syndrome. Let's discuss other answer choices. Answer choice A and D are incorrect because these tracts would be injured in Brown-Sequard syndrome. In anterior cord syndrome, the dorsal columns and cervical sympathetics are not damaged. Answer choice C is incorrect because these tracts would be injured in central cord syndrome. In anterior cord syndrome, the anterior horn neurons are not damaged, and that concludes this section.